substances. We also ensure that they are dewormed at regular intervals. Okay. Then early in pregnancy, as early as the second trimester, you can start with iron supplementation. Check the hemoglobin at 28 weeks and correct with other oral or parenteral iron therapy. Now, use of oral iron is quite age-old. It was as much as the 1500s or the 16th century that you knew about iron supplementation. These iron salts that are available to us are the inorganic ones in the form of ferrous sulfate, fumarate, ferric ammonium citrate, and ascorbate. You have the organic ones like ferric polymaltose. You have elemental iron as in the form of carbonyl iron, chelated iron, which is supposed to have the least GI problems, such as ferrous biglycinate, and you have advanced iron salts such as ferrous ascorbate, having vitamin C also, which increases the absorption. What are the challenges to oral iron? This also we are very familiar with. One is compliance. Rarely does the patient take any of the iron supplementation, which is provided to her free of cost in the government hospitals because of the GI side effects, and both diarrhea and constipation occur. There is also a lot of abdominal distension, okay, that they complain about. Okay. Then there is intolerance to oral iron. And there is the role of hepcidin, which we'll go into detail with. Any increase in hepcidin is a peptide, and any increase in hepcidin prevents iron absorption. Why parenteral iron? Oral iron policy has been there since decades, and we know that anemia is yet to be preventive. We are still standing at 52.2% of the population being anemic. It continues to be a major problem, and because of the challenges of oral iron that we have just talked about.
Yeah. Dr. Madhuri, I hate to interrupt you, but I was told the session time is over.
Okay, Dr. Rosa, no problems. I was given these slides.
Yeah, no problem. So if you can summarize it.
Okay, I'll do that. Okay,
Thank
so
you
there
so
is this
much.
hepcidin, which is a peptide hormone. I'll try my best to summarize in the next 5-10 minutes.
Thank you.
Hepcidin, which is a peptide hormone that controls the intestinal absorption. Things that increase pepcidin decrease the iron absorption. And the hepcidin is increased in whenever there is iron overload or inflammation. Now, iron overload, how? If you give too much of iron, that is iron overload. So even if you give oral iron every day, it is said that iron fails to get absorbed. So probably you should use intermittent dosage of iron. Okay. We will stop it. Okay. So intermittent dosage is what is advised rather than a daily supplementation. Alternate day or preferably twice a week. Okay, and there is something called a sucrosomal iron. This is the new generation of iron, which will be a better oral supplementation. Iron absorption, therefore, depends upon the dose, the status of the patient's iron storage, the form it is administered in, stability in the gastric acid, whether it's an elemental iron, and its bioavailability. Now, parenteral iron. Earlier, parenteral iron was associated with most side effects, but you've got safer alternatives available in the form of iron sucrose, which was safe but had to be given in repeated doses. And the third generation ones are the iron ferric carboxymaltose and the ferric deoxymaltose, which are safer and can be given as a single dose. So you have the ferric carboxymaltose and you have the isomaltosides, both of which are available in India and can be given as IV single dose administration. Okay. This is ferric carboxymaltose. This is iron isomaltoside. Okay. These are not available in India, so we will skip them. Now, parenteral also has some contraindications, a known hypersensitivity, anemia not caused by iron deficiency, iron overload or disturbance in utilization, patients who are less than 12 weeks of gestation, acute or chronic infections, autoimmune disorders, and drug-specific contraindications, hypersensitivity to the drugs. Parenteral iron prerequisites are it should be administered only where trained staff is available, where resuscitation facilities are available, and with all the emergency medication tray available, and always should be co-administered with vitamin B12 and folic acid to make sure that after giving iron, no pernicious anemia overcome. Okay. The adverse effects are nausea, problems at the injection site, hypersensitivity, headache, hypotension, tachycardia, vomiting, dyspepsia, dyspnea, urticaria. But believe me, they are very, very low with the FCM and the isomaltose preparations. Anaphylactic reactions do occur, and therefore your emergency tray must also always be on hand. So adverse effects are there with all iron, whether it's oral or IV, and make sure that your emergency tray is always available. Now, iron deficiency, why we are talking so much in pregnancy? Because the three pediatric populations that are at risk of iron deficiency, the fetus, the newborn, the children less than 6 months, all three show a wide range of motor and cognitive deficits when there is iron deficiency anemia. And we know that iron deficiency impacts the neurodevelopment of the children. It may cause abnormal neonatal brain function, poor recognition memory, slower speed of neural processing, and poor bounding and maternal interaction. It also causes long-term mental health problems in the babies, risk of autism, risk of schizophrenia, and neurocognitive defects. Postnatal iron deficiency would result in lower stores in the newborn. Okay. Early onset of postnatal iron deficiency anemia. Postnatal iron deficiency could cause long-term neurobehavioral abnormalities and motor dysfunction. There could be also socio-effectiveness and risk of depression and anxiety in adulthood. So if you give iron to the baby, to the mother, it protects the baby in the form of good neuro development. Okay. So this is the pictures of the neurons which are iron deficient and which have got sufficiencies of iron. It is said that the first 1,000 days, and what are the first 1,000 days of an infant's life? The pregnancy, 270 days, and the 2 years of infancy. Okay, these are the important 1,000 days when the child requires sufficiency of iron in the form of good sources in the mother as well as after birth. In the adolescent age, growth, nutritional demand are not met by diet alone, and therefore supplementation should be given. Postpartum anemia, after delivery, it is better to give one single injection of IV iron, that is our FCM, with vitamin B12 and folic acid, and then discharge the patient. Women is ensured that she will not be anemic. Call her back for preconceptional care, evaluate and treat, ensure optimal state of health before pregnancy. So conclusion is treat anemia before she ever becomes pregnant. Prevent anemia prevent anemia for prevention of anemia-related complications in pregnancy. If we want our next generation to be smarter and intelligent, their mothers should not be anemic and not iron deficient. Prevent anemia at every level. Let's make India anemia-free and achieve SDG goals well before 2030. That was my concluding slides, Rosa. I hope it
Thank
was
you so
interesting.
much, Dr.
Thank you.
Madhuri. I'm so
Thank
sorry I
you.
had to stop you in between, but you did it well and you've
Okay.
concluded well. The only thing I would like to add, you've really explained everything in detail, is when we give FCM, we need to have a physician or a doctor present because it has to be given during a certain period of time, 15 minutes. And I think all our nursing staffs are all trained to do that. So lovely explanation. Dr. Archana, your co-chair with me. Would you like to say something before we finish the session?
Yes, I think Dr. Madhuri has explained it so very well that there's no, she has left nothing to be really added anymore, because it's very, very important that anemia has to be treated, controlled, number one, prevented for a better future generation. So thank you very much. It was really nice listening to you. And I take this opportunity, since all MP is here and all governing council members of ICOG are here and office bearer, please support my candidature for Foxy President and vote for me. Thank you very much, Dr. Shashibala, for the opportunity.
Thank
Thank
you,
you for
Dr.
being here and
Shashibala.
chairing the session.
Yeah, again, once more, congratulations for putting all MPM bringing up to the national level. I did see Dr. Sadhna Gupta here, which I would like
Yes.
to welcome as a
If
chairperson.
she's there, we can have her blessings. Dr. Sadhna, are you there?
I think I saw Sadhna.
Yes, I had all invited all my favorite persons. Come on, Madam Sadhna, please give us a few words.
So warm greetings from my side, the old friends and all the societies of Madhya Pradesh, Rosa, Archana, and all that Madhuri, whom we have really worked when we were very young, Rosa.
I know.
We have
We
traveled
are still
together.
young, Sadhna. We are
Yes.
still young.
Oh, Sheila, too ever young, ever energetic.
So, hearty congratulations, and it is great to have the governing council member from all parts of India and MP team of ICOG GCM really contributing a lot. Congratulations, Shashi, for
Thank you.
organizing this 7H webinar with all MP societies, and it is great to be together. And every state has got its own health issues, and that's why these webinars, which are focused in one region, are very, very important. So thank you, Shashi,
Yes,
for
thank you,
giving
Madam.
me personal message.
Yes, thank you so much, Madam. Now I'll request, thank you, Rosa. Thank you, Archana, for chairing the sessions. And Madhuri, of course, you made my job easy because anemia is the toughest to tackle. And you were so clear about it. Thank you so much. Now,
And
shall we move on to the next session? Yes. Dr. Dipti, are you there? Dr. Mudita? Mudita?
Yes, madam, I am there.
Yes. So you very well take up be on the saddle. And shall I read your CV? Where is Mudita's CV?
नहीं मैम मेरे सीवी की जरूरत नहीं है
Okay, Mudita, our latest secretary, Pampox. Come on, over to you.
Thank you so much, Sheila ma'am and Pam ma'am, for having all of us here on this platform of ICOG. Now we are
Try
moving
to
on to the
mute everybody, no? Wait, Mudita, there is so much of disturbance in the background. The backend team try to see that you mute everybody. It keeps disturbing otherwise. Just see to it. Corona team. Yeah, go ahead, Mudita.
Okay. Now we are moving on to our second session of hypertension in pregnancy, the silent storm. The chairpersons for today's sessions are Dr. Nilesh Dayal sir, Dr. Shashi Srivastava madam, Dr. Rekha Vadhwani madam, and Dr. Vranda Joshi madam. Can I have series of all people, please? Thank. I think इसके बाद वाला CV. Yes. Please display Dr. Nilesh Dalal sir's CV. Dr. Nilesh Dalal sir is very senior professor and he is at present head of department in MGM Medical College. If Corona people are there, please display the CV of the chairpersons for this session.
When you say कोरोना ना तो वो पुराना कोविड वाला कोरोना याद आ जाता है.
Okay. So sir is very senior. Day before yesterday only we were talking to Madhuri ma'am. So Madhuri ma'am says that Nilesh is, I think, 3 or 4 years junior to me. So I think he is very senior professor from in the MGM Medical College. I think
It is very difficult to catch Nilesh. So Nilesh has consented. Welcome,
No,
Dr.
no.
Nilesh.
I said I'll be there positively. Your efforts have been very good, very nice to join.
Welcome,
we welcome you,
Dr.
sir.
Thank you.
Sir has 28 years of UG and PG teacher experience. Sir has been in Mumbai at Tata Cancer for 2 years. Sir has been gold medalist throughout the
Can we
MBBS.
make CV just 2 lines so that we can proceed for the
Okay,
program?
ma'am. Okay, ma'am.
All of us
Sir
we know
is at
each
present
other.
professor and head of department Obs and Gynec in MGM Medical College, Indore. And Dr. Shashi Srivastava, ma'am is very senior consultant and she is director at Saurabh Nursing Home. Dr. Rekha Vadhwani, ma'am. Dr. Rekha Vadhwani, madam, is again very senior professor and head of department at Hamidia College. And Dr. Vanda Joshi, madam, is
Gandhi
my
Medical College.
mentor and teacher.
Gandhi
And
Medical College.
I think it is Gandhi Medical College, Bhopal,
Yeah.
our
okay, ma'am,
alma
Gandhi
mater.
Medical College, Bhopal.
अभी ना
Actually, सुल्तानिया
मृदुता के
बोलते
थोड़ा
बोलते
टाइम
ना
चलेगा.
गांधी मेडिकल कॉलेज बोलना भूल जाते हैं. आई एम सो सॉरी. गांधी
कल आओ
मेडिकल
तुम
कॉलेज
इधर.
भोपाल.
कल आ जाओ गांधी मेडिकल कॉलेज पक्के
मैडम मैं तो
बुलाती हूँ.
बहुत दूर बैठी हूँ. मैडम आएंगे अंजलि मैडम. Dr. Vanda Joshi, ma'am is my teacher from GRMC Gwalior, and madam is also professor and head of department at GRMC Gwalior. I welcome you all the chairpersons. I would like to invite chairpersons to introduce our speaker for this session, Dr. Dolly Mehra, madam.
Good afternoon, everyone. It is a pleasure to be here on the platform, and I should congratulate Dr. Palm, Dr. Bhosle. I have worked in Gwalior for a year, less than a year, but we had very good relations in the OPD. I still remember at the Madhav, that OPD, which was in the campus only, and very good work we had when Sapre Madam was head of the department, and lot of learning and lot of PG classes and training and all I had done in that 9 months of my stay at Gwalior. So that is a association with her. And thanks Mudita for introducing. And my friends all, Rosa, Dr. Srivastav, Dr. Vrinda Joshi, and all on the platform. We can have the slide for Dr. Dolly Mehra, please. Dr. Dolly, everyone knows, is a very active member of Ratlam OBGYN Society, a very true academician, I should say, a smiling face and always ready and eager to learn and share experiences. Recently, only we had 2-3 big conferences in Indore, and where she had moderated a very good session on PAS syndrome, the placenta accreta syndrome, and we had very good cases to be discussed, and I was as one of the panelists. We have Dolly, who is working from in the private sector. She has a nursing home, the Mehra Nursing Home. I feel we can start with the presentation. Now the all CVs are coming, Brenda and Rekha and all. So we can have the corona people to start with the subject on hypertension. Hypertensive disorders in pregnancy is an important adjunct, like Madhuri spoke on anemia, which is very rampant in our country. Same way, last 30 years and more, in the public sector, I've seen many cases of severe PIH, mild, moderate, very common, but eclampsia is also still coming, which we should decrease the incidence by prevention of PIH. And prevention of PIH with the use of aspirin, with early detection of hypertension, with the role of rest and higher dose of calcium is guidelines based, and detection of pregnancy induced hypertension, its correlation with anemia is very, very important, which a postgraduate and the faculty should know that the anemic patients, like discussed just now, are prone to have pregnancy induced hypertension. So we should know the cutoff, we should know what the importance of proteinuria. Edema is not that significant, and we can have drugs which can prevent the severity of PIH and then decreasing the incidence of eclampsia, which is an important and a major cause of maternal mortality, still rampant in our country and in our state. Majority of the states have controlled. So I
Thank you so
feel
much,
we
sir.
can listen to, yes, we can listen to Dolly on an important aspect of hypertensive disorders of pregnancy in this 3H session today. 3H session. Thank you very much.
Thank you so much, sir.
With I feel we can start.
Thank you so much, sir.
Welcome.
Being introduced by teacher of teachers is a
Thank
privilege.
you.
I'm really, really grateful from the bottom of my heart. And I'm with regards to Foxy President Dr. Bhaskar Pal sir, Chairperson ICOG Dr. Sheila Mane, Chairperson elect ICOG Dr. Ashok Kumar sir, Vice Chairperson ICOG Dr. Sadhna Gupta Madam, Secretary General Foxy Dr. Swarna Khadikar, and Secretary ICOG Dr. Pratik Tambe sir. My seniors, Dr. Leela Joshi ma'am, Dr. Jyoti Bindal, Dr. Kavita Singh ma'am, who's always been an inspiration, Dr. Lindesh Dalal, as I always say, teacher of teachers, Dr. Shirishi Shivastav madam, Dr. Sadhna Vadvani, and Dr. Vrinda Joshi madam. And thank you, Shashi Bala ma'am, for working so much and giving me the opportunity. So can I have the screening rights, please? Share screening. Can I share my screen, please? Corona remedies, please allow me to share my screen, please.
You can share the screen, ma'am.
Okay. Is it visible, sir, now?
Yeah. Now, no, not now.
Please give me the screening, sharing rights, please. Corona remedies.
Make her the host. You will have to make her co-host.
Madam, she is host. I don't know what she's doing, that girl. I've told her.
Today, I think Shashibala, the coordination, I
That
think
is slightly, right.
slightly
That
not
that
good.
fellow.
Ma'am, actually,
Yes.
you can share the screen, ma'am. There is no issue with that.
No, I have to get that thing, na, that screen sharing is there. I'm doing that.
That option has to come share screen.
Yeah, that
Madam,
option
check
should be there.
check
Now
on the
it is
Zoom.
Now it has started.
Now
Early
it
it
is
will
there.
come. Now it is
Yeah,
fine.
it is there now.
You can start.
So it's a
Go
privilege,
to
to
slide
represent
screen
ICOG.
and then start.
Pardon, madam?
Now you can start.
go-
I feel you can.
Yeah, you can start.
Yeah. So it's a privilege
Make
to
a slideshow. Slideshow.
Go
it's a
to slideshow and
privilege
just start
to
with the
represent
first slide.
ICOG. It's a privilege to represent ICOG, and this HDP talk is by the ICOG. So why we are talking about hypertensive disease?
Dr. Dolly, go for the slideshow and start with the first one.
Okay, ma'am, I'll do that again.
Make it full screen. It's not full screen.
Is it
Yeah.
fine now?
Yes. Now, current from the beginning, first icon.
This is the first slide, right?
Yeah. No, you need to. Yeah, first slide. Yeah, click on from beginning. Extreme left, just under the file. No, bring your cursor up. Yeah, that's right. आप बिल्कुल कॉर्नर वाले पे ले आइएगा, फाइल के नीचे वाला. Yes, absolutely fantastic.
Thank you so much, ma'am. Thank you, Anjali, ma'am.
That's okay.
So
Now you can go ahead.
Why we are talking about hypertensive diseases and pregnancy? Because, before pregnancy, during pregnancy, and after pregnancy, all the aspects are very important. And as we know that pregnancy in the low risk and the middle income countries are among the most vulnerable populations in the world. Preeclampsia is a significant cause of maternal and perinatal morbidity and mortality. Preeclampsia ranks second to hemorrhage as a specific direct cause of maternal death. So it is very important to talk regarding this topic. As we all know, there is a prevalence of around 6.2%. The risk factors are obesity and nulliparity. The impact on mother is preterm delivery, emergency LSCS, and health syndrome. And the impact on fetus is low birth weight, IUFD, and growth restriction. So now what are future consequences? Preeclampsia later in life can cause development of cardiovascular disease such as chronic hypertension, ischemic heart disease, and stroke. Children born from preeclamptic pregnancies often suffer from IUGR and SGA, and preeclampsia also increases the risk of stroke, coronary heart disease, and metabolic syndrome during adult life in children born from a preeclamptic mother. So this is very important that we deal with it during pregnancy. So this is about my today's session. Now coming to the definition, non-severe hypertension in pregnancy is a systolic blood pressure of 140 to 159 millimeter of mercury and or diastolic blood pressure of 90 to 109 millimeter of mercury without severe symptoms or signs of organ damage. Gestational hypertension is hypertension that is more than 140 to 90 millimeter of mercury after 20 weeks of gestation. Mild preeclampsia is after 20 weeks of pregnancy, a BP of 140/90 along with proteinuria that is 300 milligram in 24 hours in urine sample. It may also include mild symptoms such as swelling in hands, face, but without severe complications like organ damage. Chronic hypertension is hypertension before or after the pregnancy. So this is the diagrammatic representation in chronic hypertension. This is continued during pregnancy. Gestational hypertension is new onset hypertension during pregnancy. Superimposed preeclampsia is continued hypertension during pregnancy. Preeclampsia is new onset hypertension during pregnancy, proteinuria, visual and cerebral symptoms, low platelets, renal insufficiency, and impaired liver function test. Health syndrome, which we all dread, is composed of hemolysis, elevated liver enzymes, and low platelets. And eclampsia is de novo seizures. So now coming to the definition, this is the most important part, that the ISHP defines preeclampsia according to 2014 consensus, that hypertension developing after 20 weeks of gestation along with one or more of the following new onset condition. This is the most important line. There should be a proteinuria, that is 24-hour urine protein more than 300 milligrams, or a urine dipstick or a urine dipstick test of more than 1+, or a spot creatinine urine creatinine ratio of more than 0.3. Renal insufficiency, that is creatinine of 90 micromole per liter or more than 1 milligram per deciliter. Maternal organ dysfunction, that is liver involvement or severe right upper quadrant or epigastric pain, neurological complications including eclampsia, altered mental state, blindness, stroke, or more commonly, hyperreflexia when accompanied by clonus, severe headache, and persistent visual scotomas. Each and every word of this definition is very important. Simple clonus can also label the patient into an eclampsia. Hematological complications like thrombocytopenia with a platelet count of less than 1.5 lakhs, or a DIC or hemolysis, and uteroplacental dysfunction, that is FGR, also comes into this definition. So this I've already defined. Now, you can have an early onset preeclampsia, you can have a preterm preeclampsia, you can have a late onset preeclampsia, and you can have a term preeclampsia. So the scenario varies all throughout the gestation. Now, what is the most challenging? The most challenging would be the early onset preeclampsia. Now, why we have stopped using the terminology of PIH? Because sometimes it can be ambiguous due to evolving definition and classification of the medical literature. So we don't use the word now preeclampsia, we use the word HDP. Now, again, it can be if the systolic blood pressure is more than or equal to 140 and the diastolic blood pressure is more than or equal to 90, it can be divided. Either it is before 20 weeks or it is less than 20 weeks. If it is less than 20 weeks, chronic hypertension. If it is more than 20 weeks, if there are target organ involvement, then it can be divided into non-severe preeclampsia or severe preeclampsia or health syndrome. So this definition is new and we should all learn this definition. Now, why are we talking about preeclampsia? Because it affects multiple systems. That is, it affects the brain, it affects the lungs, causing pulmonary edema, which again we dread. It affects the kidneys, the liver, it affects the fetus, leading to IUGR, abruptio, and preterm delivery, and even the heart. So we have to be very cautious, and prevention would be better than the patient landing up into preeclampsia. Now, India has the highest number of stillbirths in the world, and hypertension contributes to 18.2% of the maternal causes. So that is why we have to work on this dreaded complication of the pregnancy. Now, why it happens? In preeclamptic pregnancies, incomplete evasion of the EVT leads to insufficient maternal blood flow and the spiral arteries and subsequent placental hypoxia. The SFLT is then secreted from the placenta, which suppresses the VEGF, resulting in the systemic endothelial dysfunction and appearance of various clinical features. So if we measure the ratio of SFLT and VEGF, we can predict preeclampsia. Now, we all know the symptoms of preeclampsia. It can be asymptomatic. There can be swelling in the feet. There can be headache, vomiting, breathlessness, blurring of vision, epigastric and right upper abdominal pain, and reduced quantity of urine. The signs include hypertension, proteinuria, non-dependent edema, rapid weight gain, brisk reflexes, which we should all elicit, ankle clonus, retinal spasm, so fundus examination is important, and the right upper quadrant pain or tenderness is also very important. How to measure the blood pressure? So measuring the blood pressure in the correct position is also very important. So it should be done in sitting position with the BP instrument at the level of, with the arm at the level of the heart, and BP instrument should be there. And the correct cuff size, that is 1.5 centimeter, the circumference of the arm. And we all know how to take the blood pressure. Mean arterial pressure is very important. And you should always measure blood pressure in both the arms simultaneously using automated BP devices, and 2 sets of readings are to be made at 1 minute interval. So correct measurement of the BP, not like, that we are measuring in a very busy OPD, but it has to be measured properly. Now, if the BP is less than 140/90, fine. If it is 140 to 159 diastolic and 90 to 109 systolic, mild to moderate hypertension. Severe is more than 160/110, and the patient should not land up here. What are the alerts? Alerts for HELLP syndrome is very important. Any vomiting during pregnancy in the second half should raise a high index of suspicion. Patient can rapidly deteriorate after initial symptoms. So early diagnosis gives the best chance to treat a patient with HELLP syndrome. What can be the abdominal symptoms which we can have in HELLP syndrome? There can be colicky pain, which is a common symptom. There can be localized mid-epigastric right upper quadrant or below the sternum pain. There can be tenderness. There can be nausea, vomiting, generalized malaise because of the viral-like hepatitis, viral illness, and because of the raised SGPT and LDH levels. And less common symptoms include headache, visual changes, ascites, and jaundice. Now, we all know that we find in the laboratory diagnosis, we see hemolysis. Hemolysis is a part of HELLP syndrome. So there will be schizocytes, the serum bilirubin will be raised, LDH will be raised, there can be severe anemia, liver enzymes will be raised, and the platelets will be low in HELLP syndrome. We have the differential diagnosis from the the acute fatty liver of pregnancy, thrombotic thrombocytopenic purpura, and pregnancy-induced hemolytic uremic syndrome. So these have to be ruled out. Now, how do you measure the proteinuria? Either we use a dipstick method, but significant proteinuria should be defined as more than 0.3 gram per deciliter in a complete 24-hour urine collection, or when the urinary dipstick is more than or equal to 2+, and even if the test 1+, it needs to be evaluated completely. Remember this, even if it is more than 1+, it should be evaluated by a 24-hour urine collection. So in a singleton pregnancy, we say that abnormal protein creatinine ratio that is more than 300 milligram per millimole is important. But in a multiple pregnancy, it should be more than equal to or more than 40 milligram per millimole. Now, how do you manage? So this is the most important. There are 2 slides which are very important. Now, if you have diagnosed that there is a pregnancy-induced hypertension after 20 weeks of pregnancy and there is no proteinuria, there is mild preeclampsia, then the treatment is an outpatient surveillance. It can be in the form of antihypertensive treatments like methyl-dopa, labetalol, nifedipine, BP monitoring that has to be done twice a day, reading on each 2 readings on each occasion. Birth weight control is important. Assessment of the protein, platelets, and the liver enzymes to be done every 1 to 2 weeks. More frequent appointments depending upon the test findings. We have to do the growth monitoring of the fetus, that is the fetal growth assessment and the AFI assessment, and the Dopplers, that is CTG, Doppler USG, that is uterine artery, and the middle cerebral artery Doppler has to be done. And remember, if you have a patient like this, she should not continue beyond 38 weeks of pregnancy, gestation. Now, if you have a severe preeclampsia, or if there was a chronic hypertension and now there is a superimposed preeclampsia, that is, if the BP is more than 160 or equal to or more than 160 by 110 millimeter of mercury, increasing proteinuria, platelets less than 1 lakh, impaired liver function test, right subcostal or epigastric pain, kidney failure, pulmonary edema, CNS symptoms, and IUG or oligohydramnios, you have to have a hospital management. This is important. A tight BP control, that is at least 6 times a day or a 24-hour BP monitoring is important. Assessment of proteinuria, body weight control daily, fluid balance monitoring daily. Laboratory tests should be done twice a week, or if it is more severe than every day. Clinical assessment, including the epigastric pain, headache, vision impairment, increased deep tendon reflexes, impaired consciousness, dyspnea, or easy bruisability and bleeding. In severe preeclampsia, hourly urine output and pulse oximetry has to be done, and a CTG 1 to 3 times a day, and a Doppler 1 to 2 times in a day. And if she lands up into HELP or eclampsia, then that is another story, and we have to work fast. Now, this was about the first trimester, second trimester, and the third trimester. So the most important thing to be read from this slide is that we have to do, with the NT scan, we have to do the uterine artery Doppler, and the PAPE assessment has to be done so that we know that this patient is prone to preeclampsia, and we can start the preventive measures from here. In the second trimester, again, during the anomaly scan, we can do the placental evaluation and the Doppler. And in the third trimester, very important that we should do the assessment of SGA, and intensive surveillance after 34 weeks of gestation is indicated in these patients. Now, antihypertensive therapies, many drugs are available. In severe hypertension, if the BP is more than 160, 110, it requires an urgent antihypertensive therapy in a monitored setting. In a non-severe hypertension, oral labetalol or nifedipine and methyl-dopa can be used. But in severe hypertension, we first give oral nifedipine. Remember, it is not sublingual nifedipine. We use oral labetalol, and then if it doesn't work, then we go to IV labetalol and IV hydrolysate. So these are the antihypertensive therapies which we have in our armamentarium. That is labetalol, nifedipine, and methyl-dopa. Methyl-dopa is not available in Indian market. But remember, when you are using labetalol, then you have to be careful regarding asthma, and there can be neonatal bradycardia and hypoglycemia, which warrants the newborn screening. Nifedipine is contraindicated in heart disease patients, particularly with aortic stenosis. And remember, we proceed with the medium dose of the same low dose medication. That is, like, for example, labetalol 100 milligram 3 times a day. It can be increased to 200 milligram also. Nifedipine has to be started 10 milligram 2 or 3 times a day. It can be again increased. Consider adding another low-dose medication rather than going to a higher dose of the same medication for a maximum of 3 medications. These 2 lines are very important. You have to start with low dose, go on to the medium dose, and beyond medium dose, you are not going to increase it to a higher dose. You can add another hypertensive, and you can add 3 medications can be added. So this is the most important thing. We are all using these drugs day and night. Now, so what should be the target BP? This is important. Tight control, that is the target blood pressure should be, diastolic blood pressure should be of 85 millimeter of mercury. Now, if the diastolic blood pressure is between 81 to 85 millimeter of mercury, we need not change our medication. But if the diastolic blood pressure is less than 80 millimeter of mercury, we can either stop antihypertensive, or we can reduce the dose of the existing antihypertensive medication. But if the diastolic blood pressure is more than 85 millimeter of mercury, then you start antihypertensive medication or increase the dose of existing medication, or you can add another antihypertensive medication. So the target BP is diastolic blood pressure of less than 85 millimeter of mercury. Lifestyle measures, a balanced diet is always useful, adequate protein, adequate hydration. Reduced salt should only be in the form of limited processed food. Regular physical activity goes a long way. She can do walking, swimming, or prenatal yoga, whatever is possible. And there should be an aim of 150 minutes of moderate exercise per week. Now, coming to this is the most important thing, and this should be the take-home message from today's presentation. And here, if we see that if the fetal counting after 30 weeks of gestation is very important, when should be done? It should be done in the morning, or it can be done within 1 hour postprandial. If there is normal activity, you can do an outpatient CTG once from 36 weeks onwards. or if it is reduced, then a biophysical profile in the form of CTG and USG is indicated. If the ultrasound biometry assessment at 28 to 32 weeks of gestation says that the fetal biometry is less than 10 percentile, then you have to assess the AFI and the blood flow Doppler is to be done. If the blood flow Doppler is abnormal or if there is a reduced AFI, then you do inpatient management depending on the gestational age. If the blood flow is normal and the AFI is also normal, then you do a fetal biometry and AFI every 2 weeks. CTG once a week from 34 weeks onwards. If there is an abnormal in the blood flow or if the AFI reduces, then you have to do a inpatient admission and you can plan a delivery at around 37 weeks. Now, if the fetal biometry is between 10th to 9th percentile, then it is fine. You can again repeat a biometry at around 36, 39, 37 weeks of gestation. Fine. If the biometry is more than 90th percentile, then you measure the blood sugar, there can be a GDM. So remember, whenever the fetal biometry is less than 5th centile and abnormal blood flow or a low AFI, then you need to urgently admit the patient and plan delivery. If the fetal biometry is between 5th to 10th percentile, a normal CPR and AFI, then do CTG and ultrasound twice a week. If the fetal biometry is less than 10th centile, CTG can be done once a week. So basically, if the percentile, if the baby is FGR, you need to do twice weekly monitoring. If the baby is SGA, we can do it once a week monitoring. But at 38 weeks, you have to deliver. Between 37 to 38 weeks, we need to deliver these babies. So this is the most important take-home message from this slide today. With reverse end diastolic flow, remember 70% of the intervillous circulation is compromised and it is the time for delivery. And a CPR of more than 1 gives us time to postpone delivery. Okay. Now, fetal echo is also very important. There are studies coming up which say that before the woman develops preeclampsia or hypertension, she already has some sort of inotropic effect on the heart. And that is why she's prone to preeclampsia. So a fetal echo in 3rd trimester for these eclamptic women or the hypertensive women, that is HDP women, is indicated. Maternal evaluation should be done in the form of cardiac, renal, fundus, and the liver imaging should always be done. And if there is a severe hypertension, then we need to give her magnesium sulfate. But remember, you have to rule out pulmonary edema, renal failure, and myasthenia gravis in these patients. We all know how magnesium sulfate is given. It is to be loaded in a dose of 4 to 6 grams of magnesium sulfate in 100 ml solution IV over 20 minutes. And then you can give magnesium sulfate in the form of infusion pump. You can also use the intramuscular doses. You can use the labetalol, first 20 milligram, then 40 milligram, then escalate to 60 and 10 milligram IV over 2 minutes, and then repeat every 10 minutes, not more than 200 milligram, remember. Hydralazine, not normally used, but can be used in ICU settings. So this is important, management of severe hypertension. Now, when do we deliver? Again, as I mentioned, the induction of labor should be recommended at around 37 weeks of gestation. So what are the indications of delivery? Preeclampsia, 37 weeks. If the BP is not controlled on any 3 hypertensive, antihypertensive medication, you should deliver. If there is severe preeclampsia, if there is health syndrome, if there is impending eclampsia, or there is an abruption, you need to deliver. If there is papillary edema, that is fundus not showing good results. If there is pulmonary edema, if there is hypertensive emergencies, we need to deliver the babies, whatever the gestation be. For the fetus, if there is severe oligo or anhydramnios, if there is absent end diastolic flow in less than 32 weeks of gestation, if there is reverse end diastolic flow, that is less than 26 weeks of gestation, a non-reactive NST, and a poor biophysical profile are indications for delivery of these babies. So immediate delivery, the hepatitis 2 trial mentions that immediate delivery did not significantly decrease the risk of adverse maternal outcomes. Immediate delivery did significantly increase the risk of neonatal respiratory distress syndrome. Women with non-severe hypertensive disorders of pregnancy between 34 to 37 weeks of gestation should be monitored expectantly. So how to deliver? Induction of labor can be planned if there is absence of maternal or fetal complication at 37 to 38 weeks. Even with low Bishop score, we can do the induction with a good success. Prolonging induction for more than 48 hours should be avoided, and cesarean is done for obstetric indications only. There should be a low threshold for cesarean. Now, intrapartum care, we all know that the patient should be in bed, epidural analgesia should be given, continuous control of the BP with antihypertensives. This is for the non-severe hypertension, and continuous monitoring of the fetal heart should be done. You have to cut short the second stage of labor. Active management is to be done, and ergometrin is not to be used. In severe hypertension, all this is followed. We can give prophylactic magnesium sulfate. We have to monitor the input-output chart in these patients. Monitor the pulse oximetry of the mother. Active management is to be done. Cut short second stage of labor. And methyl dopa is not to be used. Now, PPH is common in these patients. Why? Because there is vasoconstriction, there is hypoxia, there is less volume, there is coagulopathy, there is abruption, and there is trauma. Now, PPH has to be managed in a shared care between the obstetrician and the anesthesiologist. And we all know, as our own ICOG chair, Dr. Sheila Mane, has always taught us about the management of PPH. Within 30 minutes, it has to be done. Empty
We'll have
bladder.
a session on that, Dolly. Dolly's
Pardon, sir?
session will be there on PPH.
Okay,
After
sir.
this,
Okay,
we
sir.
can
So I'll skip that.
just.
So that is very important. Now, postpartum. So remember, we have to monitor the blood pressure at least 4 times a day. If the BP is less than 140 by 90 millimeter of mercury without treatment, or the blood pressure is less than 150 by 100 millimeter of mercury with treatment, and there are no symptoms of preeclampsia, you can discharge the patient. But if the BP is more than 160, 100 millimeter of mercury, consider HDU admission and invasive monitoring. If there is a sustained blood pressure of more than or equal to 150, 110 millimeter of mercury, start or increase the antihypertensive drug. If there is a sustained blood pressure of more than or equal to 140, 90 millimeter of mercury, consider starting antihypertensive drug to avoid delayed discharge or admission, and switch to methyl dopamine previously if the patient is previously taking. Of course, methyl dopa is not available to us, but it leads to depression. So we need to stop using methyl dopa in the postpartum period if we were using it in the antenatal period. Then we come to the prevention part. So we have our own FOXY Gestosis ICOG Gestosis score. So we have a score wherein the risk factors are there and the scores are available. So this is important. You can calculate the score. Remember the 3 score, which is important, which happens in cases of pregestational diabetes, chronic hypertension, mental disorders like schizophrenia, inherited or acquired thrombophilias, maternal chronic disease, autoimmune diseases like SLE and APLA and rheumatoid arthritis, and ovum donation technique. If it is used during pregnancy, it is a score of 3. So now, if the total score is more than or equal to 3, these are high-risk patients, and we should focus on them. And this gestation score can be calculated at the time of the first antenatal visit. So this is the most important thing. If the gestosis score is less than 3, you can have a vigilant antenatal surveillance. If the gestosis score is more than 0.3, then remember the second trimester screening has to be done by the SFLT, PIGF, the PAPA, and the uterine artery Doppler. If it is negative, then fine, she can just go for a second and third trimester screening. If this is positive, then we need to give aspirin prophylactic 100 to 150 milligram at bedtime. Fine. And counseling has to be done to these patients on the basis of gestosis score. You have to explain the risk, and precautions to be have to be explained to the patient there and there in the first visit itself. This I've already explained, so I'm not going into the details of this chart. So to run with the HDP or to run a race with the HDP, it is very important that we explain to the patient that moderate exercise, that is 140 minutes per week, will reduce 40% reduction in preeclampsia. If there is a high risk of preeclampsia, initiate aspirin before 16 weeks of gestation. That will reduce 60% reduction in the preterm preeclampsia. You can add dietary calcium if it is less than 900 milligram per day. You initiate the calcium supplementation of more than 500 milligram per day. It will reduce eclampsia by 50%. And if there is a timed birth, then there is a 35% reduction in preeclampsia. So this was the race which we ran with HTP. Thank you so much.
It was a very
Excellent.
nice, elaborate this
Sorry.
thing, explaining from prevention, picking up the patient, predicting it with all things clinical. You have shown so nicely. Even the newer parameters like Doppler, which should be included, then the PGF factor, the tyrosine, and all, which can be added if the facility is available. And the cutoffs are very nice. That what should be the diastolic blood pressure 85,
Yeah.
the target blood pressure, and what are the antihypertensives we should ideally use. I have a lot of experience on nifedipine, which we did a very good study for more than 7-8 years, and we found it a wonderful drug. Sublingual definitely should be avoided, but if nifedipine combined, then you have to be very careful about the postpartum hemorrhage because it's a uterine relaxant. But it works very well in patients where you're finding issues of controlling the blood pressure suddenly, where you want to take the patient for OT, the anesthetist is waiting. It helps in. Second drug which we found with the labetalol and all the anticonvulsant, the magnesium sulfate, the added advantage of the neuroprotective. The neuroprotective, and that has come up very well as an anticonvulsant and the neuroprotective effect to the neonate. And the neonatal complications you had shown of IUGR, the fetal growth restriction is very well taken, and how early you can detect by ultrasound and all, it will help in the milestone of the family. And counseling is very, very important. Admission is very important. Referral is very important because we have seen the FRU's referral coming very late to us, and we have very short time to save the patient. So that is very
Yes.
important. The delay in referral should be prevented. If any time the peripheral or the private sector or the FRU, CSC feel that the patient is getting bad, they should refer it as soon as possible. So that is
Yes.
very, very important. Then only we can decrease the maternal mortality, I feel. So that chunk, I feel, that has to be rectified in a state, especially Madhya Pradesh. And we should have a facility like a flying squad or good ambulances covering the interiors. That thing has to come up, the FRU referral. We have Rekha, who is a
Yes,
co-chair,
Dr.
and all
Rekha.
chairpersons only,
Then
and
I would
Dr.
like to
Ganda, who
take
can add.
feedback, Dr. Nilesh, from Rinda, Rekha,
Yes.
Shashi, all the chairpersons. Please,
Yes.
one by one.
Hello.
Yes.
Hello, Shashi Didi. I am
Yes.
Brinda here. Am I audible?
Yes, ma'am.
Yes.
Yes. So it was a very nice presentation, Dr. Dolly, and the slides are really very nicely made. The one thing that I want to rather emphasize and also highlight is primarily we all obstetricians must understand that HDP or PIH or however preeclampsia, whatever we see, is a placental disease to start with. So the mother and the baby both are equally affected. And very, very important thing is when you add blood pressure control measures like antihypertensive drugs, please don't forget the baby. Because the moment we start with antihypertensive drugs, the baby is going to get affected because the hypertension is to supply the baby more because of the placental pathology. So this important thing has to be understood by each and every obstetrician, especially to start with. Don't be very liberal in starting antihypertensive just because you cannot follow the patient. And if you start with antihypertensives, please be very clear in monitoring the baby because they immediately start undergoing growth restriction. And when the time will come that already the titer will be less and the baby is growth restricted, then we don't have any other choice but to deliver the baby, whichever gestation age it might be. So just an addition I thought I would add. Thank you, Dolly, for such a nice presentation. Thank you very much.
So, good evening, everyone. Sorry, Didi, for joining late. I was in a meeting in NHM with Commissioner Madam. and I have joined really late. But one thing very important that in every center, at least we should try to take the mean arterial pressure and proper gestosis scoring. If we do this, then also we can decrease at least, because in our center, the main cause of mortality at present in about 50 to 60% cases, it is HDP right now. Hemorrhage is now the back foot. So as per FIGO guideline, in every patient, universal screening with mean arterial pressure and maternal characteristics should be done. And if required, then we can go for all PLGF and Dopplers. This is my opinion, so that we can start the aspirin. Now aspirin is evidence-based drug for prevention with cancer. Thank you, Didi, for giving me this opportunity. Hi, Ranga. Hello, Dalal sir. Everyone.
Yes, Dolly, excellent thought-provoking presentation. The
Thank you.
session reminds us that while hypertension in pregnancy may begin silently, but our response never be delayed. So I said we should be alert.
So that's
Thank
why
you.
I named the session Silent
Silent
Storm.
storm.
Silent
Yes.
Silent
Storm.
storm.
So the
The
storm
name
is
was also very
brewing.
good.
Yes. So I only, I had to, because such crusaders are there. Thank you so much, Dolly. It was
Thank you.
excellent.
Thank you.
I
And
think all of you have told everything. And
yes,
as you said, I think Madam Anjali is here. All are attending NHM meeting. So see to it that justice score comes in your mother card,
Yes.
which is happening in Karnataka.
Okay.
We
This
have
is
already
great.
included.
Yes,
So that
definitely.
every even medical officer also starts the aspirin.
Can
Once
do
he
that
knows
prediction. Yes.
it is,
Yes.
and soon I will release the app from ICOG, and then it will be still
Sure.
easier. Okay.
Definitely, madam.
Thank
Actually,
you.
actually, I also did.
question, may I?
I also did join late because we were trying to call NHM madam for our conference. That is why even I met Dr. Rekha over there. Also, she was waiting for the meeting. We just came out and they had another meeting. Yes, definitely, Dalal sir, you have put up a right
Thank you.
front that as we get patients with lot of delay, whatever
So,
we do, we can't turn the table at that point. So definitely your mention is very right. I think we should approach our government and see to it that this point is also taken into consideration. Vrinda madam has rightly said to be careful when we start with the antihypertensive drugs. And nowadays, even the patients are so well versed, they can send their BP charting on WhatsApp. And
yes.
yes, that helps us a lot. We have a lot of patients coming from periphery who keep on sending us the reports. So there are pros and cons of both things, but the system is definitely changing. And as Rekha madam has definitely said, the next topic which we have as PPH is getting a back foot, but still PIH adds on to PPH. So ultimately, it is an obstetrics nightmare, and we can't get out of that unless and until we focus on certain things, how to take care of patient before and after if they present with PPH. So, Shashi madam, if you permit
Yes.
me.
Yes. Yes, Kantanjali.
So, are you going to invite the panelist? And just let
I,
me know, because we are
yes.
really running short of time, how to
No,
handle the panel, which has been
no,
so
no.
beautifully
I'll
made by you.
invite Dr. Dipti. Dipti will step in and make it fast. Come on,
Sure.
Dipti. Over
Thank
to
you
you.
so much, ma'am. Thank you so much. And we've had amazing lectures from the first two speakers. Good evening to all esteemed teachers and seniors. And thank you everyone for joining us here. Thank you, Pam ma'am and Anjali ma'am, for this opportunity. Now, moving on to the next topic, which I think can give nightmares to even the senior obstetricians at any point of time, that is PPH. So we have a very intriguing, engaging panel discussion on hemorrhage, postpartum from hemorrhage crisis to successful recovery. And we are immensely grateful, especially to Sheila Mane madam, because she's been with us and giving her expert inputs throughout, which I am sure are going to help us all. So for this session, we have as experts Jyoti Banglowala ma'am. I believe ma'am has not been able to join. She is the chairperson medical legal committee Foxy, and a very dynamic, straightforward person, very helping. And the second expert for today's session is my teacher Yashodhara Gaur madam. Madam is professor in OBGY department. a very senior teacher who has won so many accolades with multiple publications to her credit. As session moderators, we have none other than our conveners of the day, Shashi Bala Bhosle ma'am, better known to all of us as Pam ma'am, and Anjali Kanere ma'am. Ma'am is incoming president of our state body AMPOGS. So really looking forward to strengthening the society further under your leadership, ma'am. And next, chairpersons, we have with us Shweta Di, Dr. Shweta Paul Jha, Chairperson Modern Technology Committee. And I am quite hopeful that Modern Technology Committee also will be able to, empower us in remote tracking of high-risk pregnancies. Then we
Yes.
have Rizwala Tiwari ma'am, Chairperson Environmental Health Committee, who is genuinely so passionate. One visit to her hospital, and you can see that how deeply passionate she is about healthy sustainable living and environment in general. And then we have Amita Saxena ma'am, past president of Jabalpur OBGY Society, who has beautifully incorporated spirituality and science in every aspect of her life. So over to the chairpersons for welcoming the panelists, and then the moderators for taking forward the session. If the chairpersons
Amrita,
are not
Amrita is
there,
joined, kya? Let me
no,
see.
ma'am.
Okay, then you can introduce the
Right.
panelists. Yeah.
Yes, ma'am. So we have a very, very extensive set of panelists, a very, very dynamic experts, a good mix of seniors and juniors. So we will have a very engaging practical discussion. We have Sumitra Yadav, madam, President Indore OBGY Society, Professor at MGM Medical College, a very senior teacher. Sunita Chauhan, madam, Secretary Indore OBGY Society. Dr. Aditi Rathore, Secretary Ratlam OBGY Society, and she writes beautifully. Padma Shukla, Madam, President Riva OBGY Society, also Professor at Riva Medical College. Dr. Rekha Singhal, Secretary Riva OBGY Society, another person who writes and pens beautifully. Monica Jain, ma'am, Secretary of Gwalior OBGY Society, who is so active not only in OBGY but in the IMA body as well. Shabana Sultan, ma'am, Professor, Gandhi Medical College, Bhopal. Dr. Manju Rathi, ma'am, from Ujjain. Dr. Jagriti Nagar, ma'am, from Sagar, Bundelkhand Medical College. And also past president of Sagar OBGY Society. Dr. Vandana Gupta, ma'am, past president, Katni OBGY Society. Dr. Purva Badkur, associate professor, if I'm not mistaken, in Gandhi Medical College, Bhopal. Dr. Renu Jain, professor in Gandhi GRMC Gwalior. And of course, Dr. Shruti Malvi, hamari favorite, I don't know, blogger, podcaster, real content
Sunshine,
creator.
sunshine, sunshine.
Seriously, from Narmadapuram. So over to all of you, ma'am.
Thank you. Thank you, Dipti. You have introduced them very well. And we have such a squad. I call them the PPH squad. So, welcome. Anjali, are you there?
Yes,
Yes,
I'm
we'll
very much
start.
there. If I get to share the postpartum panel.
Yes. It's your turn now to share the panel.
Yes,
Yeah.
I'll
Postpartum
be there.
hemorrhage. All know it complicates around 1 to 10% of all births. So, get get ready, get on your saddles, and 25% of all maternal deaths are hemorrhage related, particularly in low resource setting. So
So,
this is to
yeah,
be, you should be scared of it. And just one thing I would tell, then I'll give it to you,
sure,
Anjali.
sure, sure.
Sustainable development goal is MMR should be less than 70 by 2030. So now we have to stick to this, and that is why we are so alert. And we have all of you experts who are tackling day to day, every day you are tackling with PPH. So now the case discussion, Dr. Anjali will, over to you, Anjali. You can ask
Thank
the
you so much.
case.
Thank you so much, Shashi madam. As it is a mammoth topic, madam has mammoth panelist list. So maybe I can fumble to take the name of some of the panelists, but please come forward and answer as we go through the panel. Please free to put your thought process, because basically what we need to know is how you tackle with postpartum hemorrhage at your place and what best we can achieve to make things easily available or maybe easily doable for our patient to reduce the maternal mortality rate. So as Shashi madam has said, 25% of all maternal deaths are because of hemorrhage and they are relatively particular in low resource setting. So I'll start with the case discussion. This is a case of 28-year-old primi gravida, Mrs. S, at 39 plus 2 weeks. She is admitted with spontaneous labor. Her antenatal period was uneventful except for moderate iron deficiency. Dr. Madhuri Chandra has really told us very nicely about managing anemia. Her hemoglobin is 8.8 gram per DL, which improved only to 9.5 gram per DL despite oral iron. She has no medical disorder. Ultrasound at 38 weeks estimated the fetal weight at 3.9 kilos. Labor progresses slowly, requiring augmentation with oxytocin. After a prolonged second stage, she delivers a healthy male baby weighing 4.0 kilo by assisted vacuum delivery. The placenta is delivered completely. Active management of third stage of labor is performed with 10 international units of oxytocin given IV. 10 minutes later, the staff nurse alerts. Really thankful to that staff nurse. She alerts you that the patient is bleeding more than expected. So question 1, before we can even call it PPH, what are the antenatal and intrapartum risk factors for PPH in this patient? And could this hemorrhage have been anticipated? If I may ask Dr. Rekha Singhal to please answer this question. Dr. Rekha, if you are there.
Dr. Monica?
Yes,
Dr.
ma'am.
Monica, maybe you can
Ma'am,
answer it.
this patient had multiple identifiable antenatal and intrapartum
So there Rekha
risk
is.
factors for
Yeah, she
postpartum
is
hemorrhage.
Can you hear me?
Yeah,
She should,
I think Dr. Rekha is answering. So let her go
yes,
ahead and
ma'am.
answer.
Hello.
And this patient had multiple identifiable antenatal and intrapartum risk factors for PPH. She should have been considered a high risk. Like she had moderate iron deficiency anemia, and she had fetal macrosomia on ultrasound. She's primi gravida.
A delayed second stage of labor.
And she has delivered vaginally by vacuum delivery, which is
Absolutely.
more likely for traumatic delivery. She's
Absolutely.
augmented by oxytocin, which
Yes.
is
Yeah, you are very
Yeah,
right. So
on the right.
So when we are predicting, I think Dr. Rekha has taken care of almost everything. Induced labor, prolonged second stage, arrest of second stage, use of oxytocin, and
yes.
operative delivery. So
Delivery.
all
She is
those are there.
primi gravida, and primi gravida is more likely for prolonged labor.
Yes. So
And
all those
size,
things are
baby
there.
size.
Baby
And
size.
probably if during delivery also, if we start highlighting this, maybe these patients can be put up in a place with anticipated PPH and maybe we can be more sure to really take care of them so that before PPH happens, at least we have everything in hand to take
In
care of
hand.
it.
Yes.
So the postpartum hemorrhage consolidated guideline highlights prevention. As rightly said, we should have anticipated it. Diagnosis and treatment. Prevention, we all know that hemoglobin, iron supplementation, risk factors very well told, and yes, reduce perineal trauma or spontaneous birth and trained birth assistant should be there. They already have said that the management of third stage of labor was with AMTSL, but still they have given oxytocin. We can have the choice of carbitocin or misoprostol. The things which are not recommended are the fixed dose combination, injectable prostaglandins, uterine massage, and tranexamic acid. So the calibrated drape shows 350 ml of blood loss. Vitals are 112 per minute. BP is 94 by 60 millimeter mercury. Respiratory rate is 24 per minute. Uterus is soft and poorly contracted. Would you wait until blood loss reaches 500 ml? Or would you initiate treatment now? And if yes, why? Can Dr. Shruti answer this, please?
First important thing is that uterus is still soft, ma'am.
Dr.
It's not
Shruti,
well-
please, you need to increase the volume.
Sorry, ma'am. Sorry, ma'am. Am I audible?
Yeah, a bit better.
Audible and little bit energetic.
Oh, little bit energetic. Okay, ma'am. Pam, ma'am. Thank you so much. Anjali, ma'am. Good evening so much. Thank you so much. The first thing I was seeing that the BP is not comfortable. The uterus is still soft and is not well contracted. So when we have delivered a big baby with ventouse, we will be expecting and we'll be alert for contraction of uterus. It is still soft. So first of all, we will start working on that straight away before the blood loss increases.
Okay.
Shashidri, I was
yeah.
unable to hear, so if you can recapitulate it.
No, she said that because
Actually,
Manju
Bhopal
Rathi,
is having good rains right now, so
Manju Rathi is butting in Manju. We must ask Manju questions first so that she can mute herself. So Shruti, can you again sum up just a little? Yeah.
Ma'am, we should anticipate this because the baby was big. We delivered her by ventouse and the uterus is still soft. It's still not contracted. So we should be alert.
We should initiate. What we are asking is, would you
Yes,
initiate?
yes, we will initiate and start with massage.
definitely we should not wait for more deterioration of the patient. Rather, we should have a active protocol in place.
More
Nowadays,
than
this
300 ml, the blood loss is
now
there.
even the
Pulse is
definition
more.
of blood loss has changed. So we need to have our alert system in mode.
Yes.
We should use this
There is
calibrated
tachycardia.
drapes which are easily available now thanks to Adhuna and all stalwarts working on this availability of these drapes to even smaller remote places also. This should be used so that we can anticipate the blood loss in time. So we all are aware that if it is more or less than 300, pulse rate, systolic BP and shock index has to be evaluated and we should be on alert to start our PPH protocol. So what are the first 5 things your team should do simultaneously? If I can get the answer from Dr. Shabana, because she heads she used to head the department of Gandhi Medical College, and she probably will be the best person to let us know. Khat.
Yes, ma'am.
क्या
Actually,
5 चीजें चाहिए?
I'm audible, ma'am. I'm audible.
Yes, you are.
Yeah. Very rightly said that we are not going to wait for the 500 ml because in the due definition we just increase our reflexes at 300 ml only. What are the first 5 things? Actually, we divide it and we are using nowadays PPH bundle. That is bundle, primary bundle, another is a refractory bundle. In the PPH bundle, we say it is E motive. E means early detection of postpartum hemorrhage. In the early detection, what we do quick assessment. We're not going to waste the time for the, detection of PPH like हम measure करने में time लगा रहे हैं नहीं. We quickly analyze clinically as your patient is going in tachycardia and a low blood pressure. So we start our management like giving IV fluids, massaging, oxytocin. It is in the primary bundle that we give IV fluids, especially we give crystalloids. Then we simultaneously start oxytocin. And we all know that we give oxytocin in drip, that is 40 to 60 units. In the newer guideline and also in the WHO guideline, we give tranexamic acid 1 gram. And it's very good both in traumatic and postpartum hemorrhage. And we continue this. So we start with IV fluid, oxytocin, massaging, and tranexamic acid.
So yes,
And
rightly told Dr. Shabana.
Examination of the genital tract to rule out other causes like
That
retained
I actually mentioned in the start that we do the early detection immediately.
So motive means
That is there
can
includes
you-
the detection as well as examination both.
I think if Sumitra madam is there, madam, can you tell for our postgraduate students how much crystalloid would you give? Because many times they just force it through the IV line and we save the patient because of PPH and then we'll end up with pulmonary edema. So it is like पहाड़ से उतरे और खाई में गिरे वाला हिसाब हो जाता है. So we have to be very careful.
आसमान से पहाड़ का नाम मत लो, आसमान से
Yeah, आसमान से गिरे और
There are two things I would like to point out. Thank you for including me in this wonderful panel. The first and foremost is that why her hemoglobin did not rise from 8.8 to it rose only less. So here we should have been that it could be a thrombophilia, that minor, that we have ignored there. Initially, I couldn't join through the faculty panel, so I couldn't tell, but this is something that we are missing. Second thing is that how much crystalloids to be given. Basically, in crystalloids will land up the patient in pulmonary edema. And that will lead to further problems because she's already in a hemodilutional state. Instead of just giving indiscriminately crystalloids, I would suggest that with her parameters that you had sent, it is best that you limit the thing to 1 liter, that too at a guarded line, that you have to give only maximum of 40 drops per minute. That is mega drops. If you have the infusion chamber, titrate the dose and then give. Don't give indiscriminately. And when will you activate? That is for the second person. Okay, the crystalloids that I would say. Don't give
no,
crystalloids alone.
madam, you can go ahead and take this also when you will activate the massive transfusion protocols.
Yeah, it is for all. Everyone must know. Yes.
Basically, you don't wait for the things to deteriorate. For PPH, you don't sit and wait that, okay, now this will happen and then I will do this. You have to be mentally prepared for every eventuality that is going to come in the course, in the due course. So what do you think? That when the patient will start having bleeding from all the needle pricks, then we'll start the fibrinogen and the FDPs? No. We must start beforehand. When you are anticipating that how much is the bleeding, what is the shock index? Remember, shock index is something that gives you a very good idea about the state of the patient. It should be 0.7 to 0.9. Now, if you are bordering on 0.9 to 1, you must have at least 444.
Yes.
Because you don't want to wait.
So you must have continuous drills. I think continuous drill, it should be drilled into you that all these things.
I think every day teaches you something new. Today I had a talk with the blood bank in charge at our institute, and she said that we take at least 4 hours to run ELISA. So I guess when the patient is anemic, it is not a bad idea to keep her blood sample reserved rather than running around late and transfusing something which can create problem in the future. Suppose if we are able to counsel the relatives की 1 unit या 2 unit, please दान दे दीजिए. आपके घर में बच्चे का जन्म होने वाला है. If your patient doesn't need it, maybe it can be donated to some other person. I think that will make a lot of difference. I think this was the teaching which I learned today. We had a RH negative patient yesterday and my unit was struggling. Madam, blood nahi diya. So I thought when I did talk to them, they said, Madam, we can't give the blood before we do the ELISA and it takes at least 4 hours. So that was a new learning for me today. So I have told my unit people, keep it in hand, ask them to donate it. It is a good cause they will be doing for the society.
Each case teaches you something.
Yeah,
I tell
absolutely.
you. Still learning stage, yes.
Yes, absolutely. So Sumitra madam has already taken care of this talk very well. So I'll go.
Dr. Purva is saying something in the chat box. Dr. Purva?
That was for the patient tachycardia.
Someone asked about the
systolic
shock
BP.
index.
Okay.
So it is heart rate by
One point I would like to point out. One point I would like to point out.
What I want to just add, in this cases, we can do a cross matching beforehand.
Absolutely. That's what I was trying to tell.
That's what she's saying.
Yeah. So case progression,
Can
despite
I add something?
despite oxytocin infusion and uterine massage, bleeding continues. Estimated blood loss is 900 ml. Pulse is 122 per minute. BP is 88/54. So which uterotonic would you administer now, in what sequence? What would you give? When would you give ergometrin? When would carboprost be avoided? Where does misoprostol fit in this? If I can ask Padma Shukla madam to answer
Padma.
this.
Yes, Padma is the best person.
Yeah, good evening, madam. Thank you for including me in this prestigious webinar. Yeah, we can give her oxytocin. If she doesn't respond, then we can give her oxytocin plus artemether fixed dose or prostaglandin. But we have to take certain points in mind that if we are giving prostaglandin, then patient should not be asthmatic or cardiac disease should be ruled out. Misoprostol can be given, but carboprostol cannot be given. Ergometrin also, patient is hypertensive or RH negative, or patient is having any asthmatic, then also we should avoid the ergometrin. So I would
Manju, please mute.
that as this patient is moderately anemic and she has lost 900 ml blood, so along with the second line of drugs, oxytocics, we should manage, we should do the one more thing is that her bladder should be empty, she should be catheterized as well, which has not been said till now. And patient, we should start thinking about the balloon tamponade or suction catheter or suction SR cannula we can utilize that also.
Yes. What you are doing exactly when you are
Can I
such
add
case?
something?
Tranexamic acid also.
Yes,
should
ma'am,
be-
tranexamic acid can be given. No doubt. And
So
it should
that
be given
said,
within 3 hours. Within 3 hours. It should not, after 3 hours, it is not effective.
Can I add?
yes, yes, madam,
Yes,
please go ahead.
yes.
Ma'am,
Yes.
what I have seen is that people rely on prostaglandin pessary a lot. Okay, that is methyl prostaglandin.
Miss.
In my opinion, in the number of cases I've seen, it is not that good as a oxytocin compared to your age-old oxytocin. What we can always do is that since we fear IV oxytocin so much, causing you can say fluid overload, you can use IV in combination with intramuscular oxytocin. Now, if you remember some few 15 years back, from IV we shifted to IV intramuscular oxytocin. And that is also very effective. What we must do is we must not forget that we should not lose the massaging of the uterus. What people do is that they forget to massage the
Massage.
uterus and start with all the drug therapy. So this is
So
something that is equally important as well as bladder
First
catheter.
step.
So
Blood.
true, Sumitra madam. I think we should thank ICOG for putting this chart where all the oxytocics are mentioned.
Yes.
And definitely, as we start with PPH, the first and foremost is call for help. Don't think that you are the God and you can do everything.
Everything.
More the
Yes.
merrier here. Yes, sometimes too many cooks, they do spoil the broth. But if you are the leader, what is being taught every time, that you have to assign a leader if there is any crisis going on.
Squad
And
leader. Squad leader.
Yes. And the leader is supposed to give you instructions, then things don't go wrong. So those are the small things which we need to learn, and we should take care of them in our labor room protocols also. So we have already talked about when should tranexamic acid be given.
Given.
So is there any benefit in delaying it until bleeding exceeds
I
1000
think Monica can answer. Monica? Yes,
Dr.
you want to
Monica,
take
if
this?
you will like to answer this?
Yes, you can hear me?
Yeah, we can. We can.
Okay. Okay, we should not delay tranexamic acid because nowadays even the anesthetists are ready with it for in every cesarean operative delivery. Once we find the bleeding is more, 1 gram, 2 ampules they usually give over 10 minutes, undiluted, slow. So there's no role. We can repeat it after 30 minutes if there is still bleeding, which is bothersome.
Yes, this is again a wonder drug which is showing dramatic changes if we are able to administer it within time limit. And as rightly told, we can't forget the other end, that is the vaginal end. So we need to examine and escalate, ensure bladder is empty, evacuate clots, check for tears with an internal examination, and definitely placenta for
Placenta.
completeness.
Yes.
Escalate
No.
if bleeding does not stop after first bundle response. So the case progresses, the uterus remains atonic despite uterotonics, blood loss is more than 1.5 liters, shock index is 1.5, the patient is becoming restless.
Restless. Now
If I can ask Aditi madam, what next? At what point do you classify this as a refractory PPH? Dr. Aditi?
I think Aditi
Thank
is
you,
not.
ma'am. Here, ma'am. Yes, ma'am.
Yeah, she's here.
Good evening, ma'am. Thank you for the opportunity. Ma'am, when we use the first bundle techniques and the bleeding is still unresponsive to all those measures which we have taken, then we have to take it as refractory PPH. That is, we classify it as unresponsive bleeding. So, and we have to escalate our we have to escalate our next steps, basically. So we have to we have to go for compression. We should try aortic compression or bimanual uterine compression, or we can go for intrauterine balloon tamponade or non-pneumatic anti-shock garment. And also can use SR cannula also.
Yes, so true. So we need to go ahead with the refractory PPH bundle to be in place.
Ma'am,
so
I would
the
like
next
to add
question
here.
is,
I can see Madam Veena Agarwal madam has also joined. Welcome, madam. She is the authority in Gwalior on PPH. So, Madam Anjali, can you see her? We can take her.
no, Shashi Didi, I'm unable to see,
Desk
but
boss. Desk boss.
Desk
She's
boss.
there at desk boss.
oh, okay. Yeah, the boss is the boss.
Boss is the boss.
So the question
So,
is, which would you perform first? Bimanual compression, aortic compression, uterine balloon tamponade, or all together?
All together,
That
ma'am.
question goes to the young and dynamic
All
Purva
together.
Matkur.
Ma'am, we will go for all simultaneously. PPH gives no time. So we should be with our team. We should be very much doing everything simultaneously. So in outtake compression, we ask our one of the team members to compress the aorta at the umbilicus level and feel for the femoral pulse. And if it is absent, then the outtake compression is then we go for tamponading. There are
can't hear.
Dr. Purva, we are
it
unable
can
to
be
hear
Yeah,
you.
done.
your
And
network is
along with
down.
this, hello,
Yeah.
Yeah,
Go
go
ahead,
on.
hello,
please.
hello. Am I audible now?
Yes,
Yeah.
yes, you
Ma'am,
are.
then
Go
we will
on,
go
go
for
on, go
balloon
on. Now,
tamponading.
now.
Yeah. For balloon tamponading, we have various types of balloon, ma'am. One of the very effective balloon is Bakri balloon, which is having two channels. So one is for the input and other is for the output. So if the bleeding continues, then it can be revealed very well by that balloon. There are other type of balloon like Chhattisgarh balloon and condom tamponade balloon. These are the various types of balloon which we can use for tamponading.
Yeah, so Dr. Purva has rightly said that all forces should be ordered to start working together. You can't wait to have one and then two and then three. Everybody has to be assigned the work and all teams need to start working. The case progression is a Bakri balloon is inserted. We at our place don't have Bakri balloon, but yes, the government medical colleges do have Bakri balloon now. So
Okay.
initially the bleeding decreases, but after 20 minutes, fresh blood appears through the drainage channel. The patient remains hypotensive. My question is, has the balloon failed? What does a negative tamponade test mean? How would you wait longer or proceed to surgery? If I could ask Dr. Renu Jain to please answer this question.
Ma'am, even on after insertion of this intrauterine balloon tamponade, the bleeding is still there. That means the tamponade test is negative. Tamponade test negative means that we have to proceed to further for other surgical methods, maybe conservative or definitive surgery like hysterectomy. First, we have to inform the anesthetist. Senior anesthetist has to be informed. OT sister has to be informed. We have to make arrangements to immediately shift the patient to OT. Till now, we have not shifted the patient to OT. I think we should do this earlier when the patient is in shock. Inotropic support should be started. Norad drip should be started, and blood has not arrived till now, I think. So blood should be in our hand. Blood, FFP, and platelets should be in our hand. Then we have to shift the patient to OT. And after taking all high risk consent, after taking risk of hysterectomy, we have to proceed for laparoscopy. And during laparoscopy, we have to see again the vitals of the patient. If the patient is bleeding profusely, still the vitals are deteriorating, then instead of trying to conservative surgical methods, I think she's a primary gravida, no doubt. We should try to conserve the uterus, but seeing the scenario, the patient is already, I think, around 40 minutes has already passed, and we have not still able to control the bleeding, and patient is still in shock. So I think we should think about hysterectomy.
So rightly said, UBT device has to be placed before the onset of advanced shock. That is one take home from here. And as rightly said by madam, that if uterine atony does not respond to second line of uterotonic agents, definitely we should go ahead and look for what the ethical and evidence-based recommendations they say. So the patient is shifted to theater. Renu madam has really said that the consent is important. Keeping the OT staff and OT alert is important. So when the patient is shifted to the theater, what can be used while transporting the patient to the OT? If
Sunita Chauhan is there, Sunita Chauhan.
Yeah, if I could ask Sunita Chauhan madam to talk about
Yes, ma'am.
anti-shock garment.
Sorry, ma'am, for joining late. I was stuck in a case.
No,
So
that's okay.
we should shift the patient with proper applying this non-pneumatic anti-shock garment, and it should be applied from lower to upper side. Likely, the first pad should be applied first, then second, then third, fourth, and then fifth. Likewise, we should shift the patient after applying the anti-pneumatic shock garment, and with blood should be ready to open the case. We should check the platelet counts and CBC again, and whatever is deficient, we should arrange.
So true. I still remember in our VPCon, Sheila madam was there for this workshop at our place.
Yes.
And she so beautifully illustrated how to use this garment. Like we all were mesmerized. कि कितना जल्दी खोल के कितना जल्दी मैडम ने बोला, and her thing was you just need to learn it. You can't wait to see कि पहला कहाँ जाएगा, दूसरा कहाँ जाएगा, तीसरा कहाँ जाएगा. And that was another learning lesson. And the another thing which I would like to mention is we all think that these things are expensive, but I was fortunate enough to get one of these at my place just by asking the management to provide us with one. So I think we should keep on trying.
Yes.
Maybe kahin na
Dr.
kahin
Preeti Kumar bhi aaye. She had come to Gwalior, I
yeah,
think.
so kuch na kuch to definitely will be there on our hand, which can work wonders for the patient.
Anything for the patient. You have to take all measures.
For the patient for that particular time period.
Yes.
So,
Actually, Anjali ma'am, it's really important because some Jeevdaya Foundation provided it to district hospital also for the transport
Yeah,
of
but
patient from
madam-
one center to another center. Also, it actually saves the, vitals.
yeah, but Jeevdaya
Because,
doesn't take care of the private institutes. They took care of the government institutes, but thank you, we were able to procure it. So I was very happy the day when I got it.
Actually, people are donating ambulances and
Yes.
everything, like all those big companies. We should ask them to donate these things first. So,
What is the cost?
If
the
nothing works,
corporate,
then,
yes.
then definitely selective arterial embolization, but that is a restricted procedure where the facilities are available.
But radiology
Definitely we can do
intervention
it.
should be there, yes.
Uterine packing has no role.
Not recommended.
Selective embolization also doesn't work that easily. Once the
Absolutely.
patient is in a bad condition, you try it. It
No,
usually
it
saves
doesn't work.
this thing.
You do not
It
give
doesn't
the
work.
time.
It only
Then
works
for
if you are
selective
doing the
uterine
prophylactic
embolization,
one.
patient is
Yes, it should be
Then-
prophylactic.
Then
The
what works,
probe is
Sumitra?
inserted before.
Then what works when the patient, like you are tackling all the end stage?
Madam, the thing is that the period that has lapsed from when she delivered, That is the most important period. You
Crucial
should
period.
you should actually do the management within an hour. If you
Hmm.
are, they say in books, golden hour is to this thing. No, try to shorten the golden hour to 30 minutes, 40 minutes. You have to be
Hmm.
actually very proactive. If the bleeding is not being controlled, you have put in a bakri and she's still bleeding, take her to OT immediately, continue it, open, see what systemic devascularization you can. And
Yeah.
if you're suspecting a placenta, accreta, percreta, increta, and you're thinking of embolization, it's not
It
necessary
doesn't
that
work.
this will help. I've
So
operated
true.
cases of protein C deficiency without any embolization because it's so expensive. It's not easy.
Hmm.
So
Yes.
true. And it takes time also to put everything into like in the working fashion. You don't get
No, you have to
emergency.
be in a OT where the C arm is
Yes.
also there.
Yes.
In best
So
Yes.
possible
I'm able to
conditions too,
see,
it is not
I'm able
possible
to see
to,
God.
it is
You
leaving
can
out
anti embolization.
embolization.
I'm able to see Gaur madam.
Basically,
Gaur
we can
madam,
do
Yes,
even
Shrodhana.
the
Yes,
She's our
line
I
which
was
is
expert.
saying
there in
that,
red,
yeah.
formal protocols for referral. You also are from one of the leading teaching institutes.
Dr.
Madam, are
Yashodhara.
you happy with the referrals which you get at your place? Because even Foxy is trying so hard to make things aware, like the referrals should be there in proper way. Things are changing. I have seen couple of good referrals, and as I mentioned in the one of the last webinars, now we can openly talk to the obstetrician who is sending the patient and ask them. There is change in attitude. At least we get good answers. So, what is the status at your institute?
In Gwalior, you are asking me?
Yes, madam, in your medical
Yes.
Yes,
college.
you have rightly said that yes, referral has changed, and the doctors, the obstetrician who are sending, they contact we people that
Wow,
yes,
that's
we are
nice.
sending. So
That's
we
nice.
have prepared one obstetric referral group also. In that
Okay.
obstetric referral group, the Gwalior, Chambal Sambhag and the nearby colleges हैं जहाँ से referral आते हैं, they are all in that particular group. So if in case any assistance is needed or if any information is to be given that yes, we are sending such type of and direct contact is not available, then particular that obstetrician can post that detail or that referral paper on that particular group so that the person who are on duty immediately comes to know that
Knows
yes,
about it.
type of patient is coming. So
Yeah.
that's why the mortality, as it is already mentioned, is from PPH is reduced because of
Reduced.
the efforts of all the obstetricians so nicely
So true.
working and day and night. I must say that the nightmare PPH now is not so much, but we want to reduce further mortality by acting fast. One
So
more
true.
thing I would like to add that senior obstetrician should always be involved since the start. A
Yeah.
senior
Sure.
institution, and the second is the preparation.
Call
When
for
we
help.
are doing one step, we should always think of the next step. So while we are managing in the first stage, that is refractory PPH, we should at that time only we should alert the blood, we should call the blood, and OT should be prepared. So if we remain prepared, then only we can reduce the mortality because of the atonic PPH, because time is
True.
time, as Dr. Sumitra has rightly said, time is very important. That 2 hour
True.
golden hour is for observation. That is not for the management of PPH. We should act fast. And the one more point which I would like to tell that the management of PPH is not a single person, 2 person, 3 person work. It is a teamwork.
That's what
Actually,
Absolutely.
4 to 5 persons around the
Absolutely.
patient are needed. In OT staff is needed. If suppose patient has to be referred to the higher center, then ambulance driver and ambulance staff must be alerted prior to the shifting, and the even the ground staff, the by and all those who are working in the labor room, they are also so much experienced and they should be involved in calling the thing.
Absolutely. Absolutely. I think their involvement is
Yes,
required for one more thing. They know
yeah,
what the situation is and they
yes,
don't go out to tell something which is not a reality, because that will create a lot of chaos in the patients and the relatives if they say something which should not be said or which is not a reality. So even the leader is
you
supposed
rightly
to tell
pointed out.
them to
Yes, we have to
don't
involve them
intervene,
and
and who is
yes,
supposed to say.
that is the worst thing.
Sumitra
that's a
madam,
very
if I
important
can
thing. Yeah.
bring you back, what would
Yes,
you your surgical intervention sequence would be.
Yes, I'll be telling. Somebody has written in the chat box that if there is, after this, we should proceed directly for hysterectomy. Here, I would
don't
like to
think so.
comment one thing. That do not
That
proceed
is
to hysterectomy.
Amrit Gupta from Lucknow. That is our
They
Rani. Yes,
do
she's a
not,
senior gynecologist,
yes,
obstetrician.
yes. She was at Gwalior, isn't it, before?
Yes, she's
Yes,
from
yes,
Aurora
yes.
Madam's daughter. Aurora
Yes,
Madam's
yes.
daughter.
She
I
was
could
senior
make out.
to us. Yes.
Yes. So, no, I wouldn't proceed to hysterectomy because we all know that in a primary gravida, proceeding to hysterectomy has invited more than enough litigations all over India. We know the proverbial case of Lucknow where the gynecologist had to leave the nursing home and run away.
Yes. Mm.
So let's not get into that. That's a wrong thing. Now, how do we proceed? Once you open, I would go for systematic devascularization first, bilateral uterines. Now remember, whenever you're going for bilateral uterines, we forget the posterior branch of the obturator. So uh, that needs to be ligated by dissecting the bladder in 3 places. So these are the 2 important points. This will usually lead to the bleeding closed. The bleeding will not occur. If at all it is there, then you will have to go for the ovarian devascularization at the cornu. After that, you may apply B Lynch or internal iliac, but I am not a like I used to do internal iliac very often, almost nearly 40 per year, but now I am not doing even one in the last 15 years. That
Okay.
is not required. It takes time. It is very difficult if in when the patient is bleeding, and if she is in a bad state by the time you close the abdomen, you're going to lose the patient. So all this has to be very quick. This is my way.
Okay.
I would like to add
Thank you.
here that the internal artery ligation in expert hands like Dr. Sumitra, it will take hardly 10 minutes.
Less than
No,
5 to 10
that
minutes.
is not required at all. If you,
But
there are 2 branches, the anterior and the posterior. The
yeah,
posterior branch we miss. We are
Yeah.
ligating only the anterior branch
Anterior branch.
when we
Anterior.
ligate the uterines. So
yes, yes.
if you ligate the posterior division, I'm sure Dr. Anjali will concur with me that this leads to nearly in 90%. There is no more bleeding. We were taught in a manner that you go for all these.
Oh,
That
Dr.
is
Sumitra is really having a
The
bad UR. I'm
Yeah,
sorry to
yeah.
put you through this.
hysterectomy,
Doctor,
in this case, hysterectomy, the option of hysterectomy is suggested to the participant. And I think the was 2 to 2.5 liter loss is there. And so if we want to save the much, sometimes we have to take decision of hysterectomy in this case.
so
Even
Yashodhara, you are
after
doing that?
vascular bleeding doesn't stop. Yeah.
You
So,
are
Yeah.
Shashi Madam, would you like to take it further from here, forward from
Yeah,
here?
yeah.
Please do that.
Yeah. Question 11, we have come to that. No? How would you sequence your surgical
Yeah,
interventions?
we are almost done.
Yeah,
The
almost done.
questions are done.
Yeah.
Ma'am, can I
Yes.
ask?
Ma'am, may
Yeah,
I
please,
just
Yes,
please.
need
yes.
to
One
add
by
something?
one. Yes, add. Rekha?
Ma'am, is there any role of factor 7A as
Yes,
a patient
yes,
is
yes,
Yes.
definitely,
tiny and if the
definitely,
condition improves?
definitely. I've seen it
Yes.
improve in many cases. It's a very
Role of
important thing.
what, if I may?
Factor 7A,
7A
Yeah,
for
yeah,
clotting.
definitely.
if it is available.
Yes. At least in major cities, there is one hospital which has it. And I did talk to them and they were very happy. They said कि हमको बस बता दो और हम release कर देंगे. So you have to be fortunate to have
No,
that
no,
kind of a liaison with
I'll
people
tell you
around.
something. It is easily available, and even in the government setup, it is available.
Yes.
I have used it, I think, twice or thrice, and it has given me wonderful results. Wonderful.
So why don't
Hence, I
we
didn't
make
have
it
to open.
then why don't we make it into our guide? Like we should keep it.
because it is
See,
not
Yeah.
people,
available.
It will
like, I'll tell you
eventually
why
come,
it is
Shashi madam. It will
everywhere.
eventually come with ICOG and you working on it.
No,
Yes.
And
I'll tell
Sheila
you
madam
what.
working on it, the protocol
No.
will definitely
Protocols
increase.
have to, yes,
It
update
will,
or
it will.
something. Yes, I mean, practically you are getting results, as Sumitra says.
So
So
would
we
you
should.
like
No,
to
no.
close it,
I'll tell
madam?
you why.
Yes,
Why
yes.
that is
Not
not put in
always it is
protocol.
needed. Not always it is needed.
Yes, ma'am.
Yeah.
Yes.
Not
And
People
always.
it
use
should
it
not be
half.
the first
Use
line.
the
No, you may not need it, but you have to have it.
Yes, ma'am.
Like you never know,
Shashi
right?
madam, you
So
can't
yeah,
keep it.
yeah.
Shashi madam, you can't keep it with you like this. It is usually difficult to procure and availability is also less.
Okay.
Many times we don't use it. Lot of orthopedicians and trauma cases, they do use it. So that
Okay.
they become it as a priority. So we can't keep
Yeah.
it, store it like that. It has to be open
First
for
is the
We
all.
can always
mandatory.
borrow, no?
Yeah,
Borrow from them.
we can get it if we anticipate that
Yeah.
this patient may need it. Definitely it is usually there.
I'll tell you what people do is that take a shortcut. That okay, ये तो किया ये क्या now let me put IV factor 7A. No, it has to be used when it is required.
Required,
Nah,
absolutely.
that's what she's saying. Yes.
Absolutely.
Okay.
Yes, madam. And
So,
other primary measures should be taken beforehand. It's not like
Right?
we'll
absolutely,
give
very
Absolutely.
right.
factor 7.
So Rekha has put up a very pertinent question. Thank you, Rekha.
Really.
So
So, the
anything
thing
else
is,
we are
I want to add
any
one thing.
other
left
input
behind?
from the learned panelist?
Ma'am, this patient should be delivered by cesarean section to avoid all these things.
So that's
Prolonged
what
cycle
step
stage,
subsequent
prolonged
Madam,
is.
cycle
Yes.
stage for delivery.
but
Can
you,
I add? Can I add?
madam, but you can't say this because you are trying to avoid primary cesarean sections. You want
No,
to
no, I
reduce
can
the
add
rate.
one thing. I can add.
And
In
come
a
on,
4
come on.
kg, 4
4
kg baby
kg.
weight lady who
Ah.
has had a labor which is almost 24 hours,
Yeah.
and if
Yes.
you're going for a cesarean, you will again have a PPH,
Have
and that
PPH.
will be more
Absolutely
massive,
true.
more difficult to manage because you won't be
Absolutely.
able to apply the Bakri balloon in that better fashion. You won't be able to do things. So it is
Absolutely
Okay.
true.
really difficult.
Ma'am, I want to add
So
one thing. Can I?
yes.
You should have acted before.
Yeah, ma'am.
Yeah.
And
That's what I'm
but
telling you.
remember,
इतना
in
delay
in
नहीं
a
होने देना
hemoglobin of
हाँ,
चाहिए
इतना
था.
delay नहीं होने
9.5,
देना चाहिए था. Decision
Madam,
should
in
take an
private
earlier.
practice,
That's
in
There
what
may
private
be
practice,
some extent of cephalopelvic disproportion must be there in that
yeah.
case. That's why the
Nowadays,
second stage is
UAC,
prolonged, and then
yeah.
it is led to the instrumental delivery of ventus applied,
Yes.
and then
So
it was
whenever
delivered.
we have a look at the ultrasound report, we should make a point to look at the fetal weight also. We should make it a
Uh,
So
point.
the boy weight is given in that case.
Weight is
0.9.
always mentioned.
So that is
0.9.
what it is. And
Ma'am,
the
in
biparietal
private,
diameter, all these things should be taken into
Doc-
consideration
Dr.
to look for the ultrasound.
Anjali,
So
Ah,
Dr.
what is the?
Anjali, ultrasound can be extremely inaccurate. So
Oh
you should know
yeah.
to
Yeah,
By
very
manage
true.
the
clinical,
weight
by
yourself.
clinical
madam,
assessment.
obstetrical examination पे भी पता पड़
Yes,
वो
जाएगा.
पक्का वो अपना
We come
प्रैक्टिकल
to
से ही.
know.
You all
लेकिन
have
अब
Midas hand, so if you put if you put your hand on patient's abdomen, you will
you
get
come
can
to
so
know.
many things. So that
yes.
can't be left
So
like नहीं देखा और नहीं किया नहीं होना चाहिए. So
so
definitely it has to be
yes.
taught again and again कि भले ही कितने भी
patient
सोनोग्राफी हो कुछ भी हो, आपका हाथ जगन्नाथ है और
नहीं,
वो
when the
आपको यूज
patient
करना
walks
ही
in,
है. You
जब चलता
can't
है, yes,
let it
Anjali,
go.
when they walk in also, then also you can see, अरे ये करेगी गड़बड़.
Anticipate. Yes. So
So
if
what are
Shashi
the
madam, if you
private
yes,
give me,
practice, in
shall I
private
call
practice,
it a close,
I
like
have
yes,
with
yes,
the
there is
take
a
home
question.
message?
Shruti,
Dr. Shruti is asking.
yes, come
Shruti
on,
wants
last
to ask
question, Shruti,
something.
ask.
I just want to say कि private practice में when we are alone, there are a lot of things we have to take care of और उसमें हमारे पास यदि आप जैसे senior teachers हमारे आसपास हों तो it will be a वरदान क्योंकि we call for our senior colleagues and that helps a lot. Communication with the relatives is so important. Every step has to be told to them. And
Documented.
some person, yes, and उनको भी लूप में रखना पड़ता है कि अभी ब्लीडिंग हो रही है, अब मैं 10 मिनट और देख रही हूँ, अब ये है, ये डॉक्टर श्रीवास्तव है, मैंने इनको भी बुलाया है, ही इज ऑल्सो लुकिंग इनटू इट. दे शुड बी टोटली, उनको कम्युनिकेट भी करना पड़ता है मैम.
So true.
अकाउंटेबिलिटी
हाँ,
पार्टनर अपने पास रहते हैं जब कोई सीनियर पर्सन साथ में है. एंड मोर ओवर इस तरह का चीज डील करने के लिए पहले से हमको सब इंतजाम करना पड़ता है। ब्लड पहले से लगाओ, एनेस्थेटिस्ट को पहले से बुलाओ,
Yes,
पहले
yes.
से बुलाओ।
That's
तो
why
we
there are
So,
this
so
factor of PPH. We have
three
to
take home
identify.
messages we have to
we
go.
treat every
Yes.
patient as that of PPH and then we go about it, तब हम survive कर।
नहीं, I would
Yeah.
like to ask Jagriti. She is practicing in Sagar.
जी मैम।
Sagar में Jagriti, what is the scenario like in Sagar and Katni also? Those two panelists are left.
मैम सागर में भी बहुत ही रोज ही हमारे कॉलेज में तो इस तरह के केस रोज ही आते हैं और बहुत ही डिले होता है रेफरल में, तो काफी बेड सिप में पेशेंट्स आते हैं। पर ये पीपीएच के लिए हम बिफोर हैंड अगर प्रिपेयर्ड है और अगर प्रिवेंटिव मेजर करते हैं तो काफी कुछ
तुम्हारे
हम सेव कर
आपके
सकते
यहाँ क्या क्या अवेलेबल है जागृति? व्हाट ऑल एग्जैक्टली यू आर डूइंग?
हैं। मैम
तीनों
हमारे पास
चीजें कर
सब
रहे हो
अवेलेबल है।
प्रोटोकॉल के हिसाब से? Okay,
मैडम
okay.
फ्रॉम जीवदया फाउंडेशन वी आर हैविंग ऑल दीज गारमेंट्स भी, इलावी बलून्स भी, सारी
अरे
चीजें
वाह,
हैं।
very good. That's
Very
good
nice.
to
Very
know.
nice.
Very nice. And
Jagriti
Katni
is
से
anyway a very hardworking
very hardworking.
faculty. I know her
She's the
such a long time.
face of
So
Sagar है वो.
absolutely, absolutely.
And I
And
think
doctor from
yes,
Katni,
Katni, Vandana, where are you? Vandana Gupta from
Dr.
Katni. She
Vandana
was there.
Gupta, if you are there, if you could pitch in from your place how the local culture
हम
is.
जबलपुर से चेयरपर्सन है अपने पास अमिता। जबलपुर से कोई वो नहीं आया इनपुट।
Yes,
Amita is the
ma'am.
chairperson of this
Yes,
panel.
ma'am.
Yes.
Sorry, I joined late. Thank you for involving in me in this such wonderful webinar. Anjali madam did the justice. बहुत अच्छे से panel moderate किया madam ने.
Thank you
And
so much,
every
madam.
time we
Shashi,
listen to
Shashi
this
madam ने
topic,
बना
we
के
become
दिया
little
था,
wise.
मैंने कुछ मेहनत नहीं
Yes,
की।
yes. But
भैया
every time madam, अभी 30th
all
को भी अंजलि madam को सुना था. She taught us PPH bundle
we are
beautifully.
very
So every
lucky.
time we listen to this
Yes.
topic and we become wiser.
Thank
So
you.
just I want to
एक एक
conclude कि
शब्द करता
intelligent
है
anticipation
no,
is skilled supervision and I
Yeah,
think proactive measures जो भी हम लेते
management.
हैं and
Yes,
effective
take home.
institution is the key for PPH. Thank
So
you,
So
true.
madam.
how do we balance the fertility preservation against maternal survival?
That we try, madam. Till end we try that to save uterus or
But decision should be
But still
yes.
saving the patient is more important if it
try.
comes
Otherwise,
to.
also if the patient has
So one
completed her obstetrics career, still we try to save the uterus if the patient.
okay. So one question from my side: if you could change one practice tomorrow in every labor room across India to reduce the maternal deaths from PPH, what would it be?
PPS drill to be done in every labor room monthly
Yes.
basis, ma'am. So all these staff should be aware
Yeah,
for any.
routine में objective measurements of blood loss. It should come into your
Absolutely.
psyche, like driving, swimming. You must know
You
what
should use it
exactly to
every
do
time.
every time. So early recognition, early action.
Mock drills, mock drills.
One question, this panel, Anjali, you are giving me the credit, but the credit goes to Dr. Purva. She made the panel and she's a panelist. And
So
Purva, one last question to you from Amrit. Amrit is asking what exactly happened to the patient? What did you do in this case? Did she end up
Ma'am,
in hysterectomy? Yes.
we managed the patient well because we have
Oh,
opted for the surgical stepwise management. So the patient was very well managed by this.
very
Also,
well. And
ma'am, one point I want to add in this, there is also role of cryoprecipitate nowadays. So that can also be used in
made
such a
arrange.
massive blood loss. We can use
That we
cryoprecipitate.
agreed upon, Purva. We had said on the massive blood
Scores with that.
transfusion protocol.
yes.
So we had added all those that
So
time.
Yeah.
Katni has come back. Katni, I can see Vandana. You have come to
Yes,
say
ma'am.
bye-bye.
What
Yes,
is the protocol at your
ma'am.
place,
I was
madam?
stuck in an emergency,
Koi-
ma'am.
No problem, no problem. How do you, at your end, you have all the system in place? You have all the system in place in Katni?
Yes,
For
ma'am.
PPH management.
You have a
Do
PPH.
you get everything at your place at Katni for PPH management? Like maybe you not get Bakri balloon, but you can have some other play thing which you can use. How about the drags? How about the drapes?
I am using, ma'am, Foley's catheter.
Okay.
Okay.
Yes, ma'am. Foley's condom catheter.
Yeah, even that's very easily made and
Yes, easily made and yes, ma'am.
Are you using
It's
those
quite.
calibrated those
are you
pads
using
and
calibrated drapes?
calibrated drapes, Vandana?
Yes, ma'am.
Are you
Calibrated
able to get
drapes?
calibrated drapes?
No, ma'am.
Okay, so I think Shashi Didi, may I take this
Yes.
opportunity to invite all of them for MPOX conference, which we are going to have on 18th and 19th of July at
Yes.
Bhopal, and maybe we are going to have a stall where you can go ahead and see these calibrated drapes, and they don't cost much. So
Okay.
you will get
Okay, ma'am.
exposure
Okay.
to that, and definitely you will see, you will realize how things are made easy nowadays for management of
Yes.
PPH. So it's a sincere.
Can I add something that you have
Sure.
added? You have spoken, Anjali. I've
Yeah.
been using calibrated drapes, and we have used nearly 1,700 drapes.
Oh, wow.
The advantage is that we are alerted before time.
Yeah.
Once you are between 100 to 300, you can sit okay, 299. Once it is 300, you take action. So none of our
Absolutely.
patients landed up in
Yes.
any surgical thing.
Sure. So true. So true.
So
It is like जैसे पहले से शुरुआत के पहले दिन के हाउस जॉब से सिखाया जाता था, यूरिन आउटपुट मेजर करो,
you
नहीं
drop by
की,
drop.
हाँ नहीं की, तो
Patil,
बहुत सारे
Patil madam,
सीनियर्स
we
यहाँ
have
पे,
worked with Patil
बहुत सारे
madam.
सीनियर्स हैं जो डांट लगाते थे. वैसे ही
Oh,
I think we should make a point for using these drapes
yes.
and seeing how much the blood
Yes.
loss is
Very
And they
good.
should
before we let the
understand the,
patient
yes,
use.
understand the importance of that. Yes.
Absolutely.
Aduna is
One
looking
more
Absolutely.
thing
after
I
all
would
this.
like to add that we
Yes.
should use SR cannula in each and every delivery.
We should
Because
use
it
SR
can be
in each and
used
every
as.
delivery.
Who
I
is
defer,
that?
madam.
Who's
Madam, I
that?
am Dr. Padma Shukla.
Okay, Padma. Ha,
And
ha, ha.
actually, I am using it and I have started using in Riva Medical College as well.
Madam, but
Before
not for
having
every
this thought.
delivery. Madam, not for every delivery.
Madam, for it is preventive, prophylactically. You should
Madam,
use.
I think we were there when we were fortunate at Indore. We were there. Thanks to Sumitra madam. We had wonderful demonstration of SR cannula by none other than the other than doctor who introduced it. And I think even he said that it should not be
No,
used for
madam.
each and every patient.
No, madam. Recently, we had one webinar with Dr. Samath Ram and Dr. Charmila madam was also there. And they said that prophylactically, when we use it, it gives very good results. And I have
Okay.
started using it. So why to wait till 300 loss? When we use it prophylactically before delivery of the placenta in the active management of labor only, then it really gives good results because it contracts the uterus and placenta comes out beautifully. So blood
Then,
Yeah,
loss is very less.
maybe
then
I don't
you,
have any hands-on experience on
then
this.
you must calibrate this. You must
Yeah,
collect
yeah.
your experience
Yes,
cases.
ma'am. Sure,
We would
ma'am.
like to know,
So,
right?
Shashi Didi, shall I
Yes.
close
Yes.
the session?
Yes.
Thank you,
Very
So
ma'am.
true.
thank
And
you everybody. Such a wonderful panel we had.
Thank you, ma'am.
Thank you so
Thank
much.
you,
Thank
Satyali
you
ma'am.
so
Thank
much.
you,
Thank you,
Shashi
ma'am.
madam.
Thank you,
Thank
ma'am.
you,
Thank you,
ICOG
Shashi.
team
Thank you,
Renu,
Dr.
for
Anjali.
all
Thank you,
thank
of
you,
Dr.
you,
ICOG
thank you,
team.
because all HODs, you are at the fag end of the day. You are not looking tired. By the name of the PPH only, you all are there with full energy. That's so true. Patient नहीं है फिर भी खौफ है PPH का. So that is really, everybody is well versed. I'm so happy. I will convey this to Sheila madam that her PPH favorite topic as really that it should end. Maternal mortality का ये कारण तो नहीं बनना चाहिए, right?
True.
Thank you,
Thank you
ma'am.
so
Thank
much,
you,
So,
everyone.
ma'am. Thank you,
I
Satyakala
can
ma'am.
It was very
I can see
Pratik sir is there.
Dr. Pratik sir is just he's there.
Hi,
Few words
everybody.
from you.
Fantastic
Yes.
panel, great program. Thank you very much,
Thank you so
Thank you.
much,
everybody,
sir.
for all your valuable time and your beautiful inputs. Hats off
Thank you
to
Thank
you.
so
you.
much.
Thank you. Thank you for ICOG for giving me this opportunity to collect all my girls under this
Thank you,
banner.
Sachibala. We look forward to more from you in future.
Yeah, sure.
Thank you, Tambe sir.
Thank you,
Thank you.
Anjali.
Thank you.
Thank you, Anjali.
Dr.
Thank
Pratik.
you,
My
everyone.
and all my
Thank you
panelists.
all.
All, yeah, all is the
Shashibala.
word.
Thank
Yes,
you, ma'am.
madam. अरे मैडम भी आ
Thank you,
गई. Yes,
madam.
madam.
Thank you, Sheila,
Thanks.
madam.
शीला मैडम
Yeah,
आप.
in between, I had logged out
Yes.
doing some conference work,
नहीं
doing calls. So I
नहीं
thought again I should
मैडम,
come back
मैडम
and congratulate all of you.
आपकी कॉन्फ्रेंस के लिए और भी क्वेरीज आ रही हैं, सो विल मेक इट अ बिग सक्सेस. ऑल
Yeah.
ऑफ यू कम
और
ऑन, नर्मदापुरम सब चलना है बेंगलोर.
मैडम हम तो डांस भी करेंगे.
यस.
बिल्कुल.
थैंक यू.
और डॉक्टर अंजलि वो पास इसका आप लोग ले लीजिए ना.
जी, madam,
MPOG.
definitely.
हाँ मैडम सुमित्रा,
Definitely.
यू ऑल्सो टेक अप दैट.
Sheila, madam, we are going to have Manjupuri, madam, and Mitra Saxena, madam, for our conference workshop also.
Very
गुड
good.
गुड गुड.
Yeah. So
एंड वो पास रजिस्ट्री भी सबको बताना आपको.
definitely we'll
ये
take
भी
the
अपने लोग
opportunity.
रजिस्टर आपके
Definitely.
MP के ग्रुप्स होंगे ना, उनको डाल देना.
जी जी बिल्कुल, उसने हम कॉन्फ्रेंस में भी अनाउंस करेंगे.
मैडम हाँ, एमपी का एक ही एमपॉक्स ग्रुप है मैडम, वो इतना लोडेड है, उसमें सबको आ
उसमें हम
जाएगा.
डेफिनेटली अनाउंस करेंगे.
Yes.
Thank you so much.
Thank you, madam, for the
So, Dr.
opportunity.
Sheila.
Thank you so
Thank you,
much.
Sheila, madam.
Dr. Sumitra.
Dr. Tarini, thank you. My ICOG GCM, Tarini is
Okay.
there.
Thank you so much,
Tarini
Bangalore.
and Sita had joined. Thank you.
Sita, Tarini, everybody adjourned. Yes, thank you.
Sheila
Anita.
madam, Sheila madam,
Hi,
convocation
Tarini.
22nd को ही है ना? 22nd
हाँ,
को है.
कॉन्वोकेशन 22nd को है.
तो अगर
शाम को
21st I have
शाम को
some
5 PM, इवनिंग 5 PM.
तो relatives
Yes.
at 21st को can I miss on 21st and join on 22nd and 23rd?
हाँ
But
बिल्कुल,
the
आप 22nd को. हाँ जरूर. ओके.
22nd में आती हूँ तो फिर उससे पहले आ जाती है, कन्वोकेशन से पहले.
हाँ, सुबह की फ्लाइट लेकर आई है तो ठीक हो जाएगा.
हाँ, सुबह का आना पड़ेगा, नहीं तो इवनिंग में पहुंचती है.
बिल्कुल.
ठीक है.
ओके डियर. ओके.
थैंक यू मैडम.
तुमने
बाय बाय बाय.
आपने देखा. और शीला मैडम, मजा आ रहा है आपकी. तो पीपीएच लेडी तो बिल्कुल सबको पीपीएच एक्सपर्ट कर दिया.
Thank you everyone.
इसलिए तो पीपीएच की मॉर्टेलिटी कम हो गई, अभी एचडीपी की ज्यादा हो गई, हम सुन रहे हैं ना.
एचडीपी, हाँ अभी एचडीपी की
और
ज्यादा
कल
हो गई.
हमने जब कर्नाटक में एमडीआर कर रही थी, सब इन्फेक्शन आ रहे
शीला
थे, तो मैंने
मैडम.
अपने हमारे डीडी को बताया, देखो अभी एचडीपी भी चला गया, अभी सेप्सिस आ गया.
अब वो जो ट्रे में आपने इंस्ट्रूमेंट्स बताए बहुत पहले, बिफोर ड्यूरिंग योर चेयरपर्सनशिप, वो सब मैंने तो तब से सेट किए हुए हैं. जब
आई
आप
नो. थैंक यू. चलो बाय
Thank
बाय.
you. Bye bye.
ओके बाय. एक क्वेश्चन ये था दिमाग में कि वो आय कन्वोकेशन कहीं लीव नहीं होती है. रूम का करा नहीं, अभी वो दिमाग में था ना.
थैंक यू मैडम.